begin. Okay. Yes, I'm just going to talk about why I emphasize the word stress and not trauma. And if you like studying language, you'll have an understanding. I hate the word trauma. It's used all the time, especially in the media in this country, but I find it very confusing. And this is why. Because the word trauma is used for the insult, okay? So the thing that you're doing can be a trauma. The receiving end can be a trauma. But then are we talking about physical trauma, which is where the word comes from? You know, the physical trauma of a broken leg or the physical trauma of being hit with an axe? Or are we talking about emotional trauma, the psychic wound to the mind, the trauma to the mind, or the psychic insult, the abuse or the stressful event? The word trauma is used for all those situations. So I never know where I am, so I don't use it. That doesn't mean you can't use it, but I really suggest if you use it that you define it. So you say a traumatic event, a traumatic reaction, an abnormal traumatic event, or an abnormal reaction, a normal trauma. It's very difficult to see, so that's why I stick with stress. Okay. Why do we get stressed? That might seem like a stupid question. It's so obvious. It's so obvious that I'm going to ask you to think about it. And I always do this little exercise at the beginning of a lecture. So I want you to imagine, and we're going to go away from our normal circumstances and imagine that we are in a strange situation, which is in itself stressful. Okay, we're in a deep, dark jungle. I like jungles and forests. And we're alone there, and a branch cracks behind us. At least we think it's a branch. It's a loud noise. We don't know why. So possibly, as well as that, and of course I know you come from a country with earthquakes, the ground beneath us begins to shake. Forget the word worlds. So we're in a jungle, a branch is cracked, then the ground is shaking slightly. Could be anything. Maybe it's a herd of elephants. Maybe we're having an earthquake. Do you get elephants in jungles in Pakistan? I'm not sure. But anyway, you get elephants in some places. Jot down in the chat response how you're feeling, ground shaking, branches cracking, maybe you hear other strange noises. How are you feeling? What are you thinking? What are you going to do? And what's going on in your body if you're aware of it? So just put it in the chat so I can see. It's just a little mental health exercise. Can I see the chat now? I just have to find it again. Yes, so just write it down and I can see what you're writing. Thank you so much. Scary jungle, strange noises, ground shaking. What are you feeling, thinking, doing, and what's happening with your body? Just don't be shy. Just put a few words down. No one's going to write. I'll give you a moment. Heartbeat getting faster, great. Feeling like I'm going to die, that's the thought, I'm going to die. Emotions are your feet, yes. Fear of dying, yes. Trembling heart, beating fast. Fear of losing what? Control. Feeling worried, great. Lack of control, yes. We've got some feelings and we've got some thoughts. Let's have some, what are you actually going to do in this situation? How are you behaving? Yes, getting out, feeling lost. Okay, more feelings, yes. Maybe run, brilliant, Ahmed, yes. So one thing you might do is run. Anxious, yes, run out of there. Anybody else got an alternative behavior to running? Freezing, absolutely. So maybe you know you're not a fast runner and you think, oh, just to hide under this tree. Hope I won't be seen. What's going on with your body? We've had heartbeat. Anything else apart from your heart? What else is happening to your body? Sweating, absolutely, if you're running. Stuck, you've got into freeze, yes, great. Any other breathing? For example, shivering, shaking, brilliant. I don't know what shivering is. Maybe that's shivering, shaking, yes. Trembling, yes. Trembling, yeah. Anything else? Any other things that other people haven't mentioned? What's happened to your mouth, your saliva? Mouth or dry mouth, absolutely. Sweating, dry mouth, drying out, yes. What's happening to the hairs on your arms? Yes, you've got palpitations. Hairs on your arms, if you're a bit scared. Standing up, absolutely. I'm going to stop you there. We've got the key points here, and I need, oops, what happened here? Need to move on. So you're getting it. You're a psychologist, so why won't my slides change? Yes. Okay. And we aren't the only animals that respond like this. Your feelings, and you put them down, fear and anxiety. Either way, you feel pretty worried and uncomfortable. You're thinking. Now, you didn't put this down, but if you're going to be afraid, that you're probably thinking, what is that? Is this an earthquake? Is that an elephant? Is that a tiger? Should I run? Should I hide? So your thoughts are racing and you're having these sort of thoughts. And then what are you going to do? And now these are very basic responses. Our choices, as in all mammals, are, can we run away from this? Can we fight it? You didn't mention turning around and fighting it. Shall I freeze? Shall I, as you've seen with small animals, roll on my back, show that I'm more innocent, avoid in some way? And these things that we've described and the way your body is responding are our normal stress responses. Our hearts will beat faster, our breath will go faster, our hair will stand on end, we'll sweat in order to keep cool, our mouth will be dry because it's really not convenient to have lots of saliva when you're running. And we've had this response for a very long time. Without it, mammals would not have evolved because those big animals with teeth and claws and scales would have just destroyed us. But our ability to react quickly has enabled human beings to get out of very tight situations or to defeat those situations. It's called the fight-flight response. Actually, stress and anxiety are essential to our survival, and they're very useful in day-to-day life. So the second exercise, don't worry, I've only got 2 or 3. The second exercise I'd like you to do, just to get you thinking, whoops, sorry about that, is please write down in the chat box when it is useful to be anxious or stressed. Just jot it down like you did before. Oh, I love it. For exams, absolutely. You need to be stressed or you go, oh, this is cool, I don't care. Great, what else? Having a challenge, yes. Exams, yes. Come on, I know you're students, but give me some other stressful situations apart from exams. Something else. You're all taking exams. Something other than exams. For example, this morning, if I hadn't been a little bit stressed, I couldn't have done my lecture. Completing work in time. In danger, when wounded, absolutely. Assignments, coping with COVID, absolutely. In any dangerous situation, we need to be stressed to be sort of revved up to do it. Yes, anybody an athlete here? Saving someone's life, talking to seniors, I love that. Yes, project completion, I can see you're all students. Yes, we've got some professors and teachers here. What makes you stressed? Achieving any goal, yes. Business task, yes. You're getting the idea, yes. Saving someone's life, I love that. Any disease you get, yes. In fact, your stress response absolutely stimulates your immune response, helps you fight the disease. Absolutely, well done. Okay, anything else before I go back? Okay, good stuff, guys. Yeah, when we don't fulfill our task, yes, that's not when it's so. When we don't fulfill, I'm getting late for prayers, yes. Here and there, that's an interesting one. Could you say more? I don't know quite what you mean by here and there when it's useful. Okay, I will continue. So you are getting the idea that anxiety and stress is useful. And often when I'm talking with patients, what I'm doing with you, in fact, is what I do with my patients. I start with having them understand the stress response. I'm sorry, sometimes my slides will progress and sometimes they won't. And I explain to them that we get anxious for a reason. Anxiety is there to help us. In many situations through the evolution of human beings, we've needed our built-in alarm system, and that's what I call it. The alarm is a hormone. Now, if you were in class, I'd ask you to shout out the name, but don't worry, I'm going to say it for you. The alarm is adrenaline, and it triggers what you've identified in the previous chat, our fight-flight response, which allows us to survive from all those big predators. But it happens in other places without us even thinking. If we're in high places, I mean, some people have this as almost a phobic reaction, but the ability to freeze, not to run in that situation, that stops us falling. The fact that we get nervous when we're standing on a cliff and we're a little bit stressed is a very good thing. We're less likely to fall off. If we're faced with someone bigger and more important than us, we're animal or we're human, we tend to follow what they do, be submissive, because that stops any threat from them because they're bigger than us. Some people faint when they see blood. Now, actually, that's not a bad thing to do because the fainting reaction inhibits blood loss, inhibits the likelihood of losing more blood. Getting frightened in social places, you've all heard of social anxiety, well, to some degree, that has a protective function. Because if you stay away from strangers, you stay safe, you stay with those you know. And of course, what we're seeing now is almost the triggering of social anxiety with COVID. Certainly in this country, the government's message of stay home has been so powerful that people are reluctant now to go out and mix with others. Not everybody, but many people having a big debate about returning to school. So we've triggered social anxiety for safety reasons, and now the public may have difficulty getting rid of it. Very interesting. And then with sudden traumatic events, and we'll come to this when we talk about PTSD, but think about it. You cross the road as a pedestrian and you're frightened of the car crashing into you. And you continue for days after that event, maybe weeks after the event. Every time you go near a road, you see the car coming to hit you. So what does that mean? That flashback, as it's called, prevents you from putting yourself in the dangerous place. Now, it may be a symptom of a disorder, or it may be a protective response that stops you going somewhere. You're alert when you cross the road, you're a bit tense, you try to avoid crossing dangerous roads if you can. That's actually protective. What I'm showing you is that these abnormal symptoms actually have protective function. Just like nightmares, very uncomfortable and painful, but actually you're reorganizing in your mind, digesting something bad that happened. Little babies, we talked about it with grief last week. We know they scream when their mothers leave them. Separation anxiety, that's the beginning of it. It has a protective function. Of course, if it stops you ever separating, it becomes pathological. Phobias, conditioned responses. What's going on? Somebody's got children in their room, no matter, or somebody else, I don't know. It's interesting that we're phobic about snakes and spiders. We're not phobic about cars. Now, arguably, cars are a lot more dangerous than spiders, but spiders have been around for a very long time, and some evolutionary psychologists say that these are archaic threats. So when we were tiny mammals and spiders were big and dangerous, it was very useful to be scared of spiders. Less so now, but the fear remains. The same with snakes. Hysterical conversion, very interesting. If you actually turn your fear into a physical disorder, it actually resolves conflict. It's a complicated issue, but many people see it as having a function of resolving conflict. Okay? And OCD, well, I'm going to talk to this about this a bit later on, but it is very interesting, again, like social anxiety, how some fears, phobias, and anxiety symptoms, stress responses have actually become useful. And we see now that, in fact, a friend of mine who's an adult psychiatrist said his OCD patients, his patients with obsessive compulsive disorders, are ringing him up and saying, see, I told you so. Very useful to be obsessional about washing your hands and cleaning the door handle, isn't it? And they're laughing. They're laughing because their fears are useful. I'm going to do. I love this story. This is some recent research. Okay, so We have two kinds of squirrels in this country. One are the grey squirrels, and they're killing all the, not killing, but they are very successful. And the red squirrels that are our natives are dying off. Except that's not always the case. In some areas of the country, it seems that red squirrels are doing better. And just a few months ago, some research came out that showed why. What happens when a common predator, it's called the pine marten, he's another animal that eats both red squirrels and grey squirrels, is around, is that the red squirrels and the grey squirrels behave in a different way. The grey squirrels go, oh, that's cool, we don't care, and go on about their daily business. The red squirrels go, oh, smells like a pine marten, and they run. Who do you think is surviving? The red squirrels. Because they're much more alert, if you like, stressed than the grey squirrels, and so they don't get eaten. My point is that stress helps us survive. Okay, we've already got this down in the chat box, but when I'm talking to I tell that story to children, they love it. When I'm talking to children, the most important thing, especially with children who don't come often from this country but come from all over the world, they don't come in and say that I'm stressed. They say, I've got tummy ache, or I've got muscle aches and pains, or they say, I feel weird, because often they feel the symptoms in their bodies more than they do in their minds. And it's very important for them, and I do this just like I did with you, and say, well, when you're in this frightening jungle, or when you're in a frightening place, what happens to your body? And you've already told me. Now, they don't tell me I've got more adrenaline or my blood's different, but they do tell me they sweat, they get a dry mouth, maybe they can see better. They certainly love it when you point out about the goosebumps, as you said, and your hair standing on end. You say, well, when you're running a race to get away, what happens to breathing? It goes faster. And of course, your heart beats faster. And then you can explain how useful all of this is. Because if your heart beats faster, your blood goes faster. If you breathe more rapidly, you get more oxygen. If your hair stand on end, well, we're not squirrels or dogs or cats anymore. But if we were, we would look bigger. And if your pupils dilate, you can see better. If you have a dry mouth, you're not going to have saliva dripping down you. If you sweat, you keep cool. If you produce more sugar, you've got energy. If your blood clots better, then you won't bleed too much. And of course, you need more adrenaline. The fight-flight response, all these things that happen are useful. That's the first thing. We need them. The problem is when we're stuck in situations where we can't actually get away from the stress, it keeps on going. The fire alarm keeps ringing, but we're not running. We're not fighting a battle. We're not alert to have an argument with a boss or give a lecture like I am due, and therefore, in a sense, dealing with that, we're stuck. And the classic stuck situation, the first situation where actually people really began to study the stress response, was the First World War. Because for the first time, soldiers were kind of stuck for long days, months, years in terrifying situations. And they began to get strange conditions like soldier's heart, which first of all they thought was a cardiac abnormality, and they set up chest hospitals. But then they realized it was a stress response. It took them time, and some soldiers, of course, got shot. But anyway, this was a classic situation where we began to recognize the stress response. So I made these two lists. These are the things I've told you about that you've identified that are useful and protect us. But when they go on too long, they're not protective. We start to feel strange. So goosebumps, we don't think, oh, that's useful, I look bigger. We just feel weird. Our vision isn't necessarily useful. It may even be blurred. Sweating, when you're sweating and you're not running and cooling your body, is unpleasant. Dry mouth, actually, women come often a woman's symptom. I feel like I'm choking, doctor. I feel like I'm choking. The faster breathing, I'm not able to breathe. I'm not able to get my breath. I've got palpitations. The blood's gone away from the gut. Actually, that can lead to gut disturbance. It's gone to the muscles. We complain of aches and pains. So as you see, As we move into these frozen or prolonged stressful situations, we're not protected by our body's responses. We actually begin to notice them and feel weird and come to the doctor or the psychologist with what are called somatic complaints, as well as the emotions. One of the classic ones, and I don't know if this is common in Pakistan, but it was extremely common in Afghanistan when I worked there, was hyperventilation. Now, hyperventilation is actually a physical disorder triggered by fear. What's going on? You're frightened. The ground is shaking. It's an earthquake. Or there are soldiers in the village. You start to breathe faster. You start to breathe faster with your chest. You've got a lot of oxygen now, useful if you're running, but you're not running. You've got too little CO2, so you actually get a disorder in your blood because you are hypocapnic. Too little CO2, too much oxygen, chemical imbalance. That hypocapnia gives you chest pain. Along with the other feelings of dry mouth and choking, you begin to get pins and needles in your hands. I don't know if any of you have ever seen, but full-blown hyperventilation syndrome, people's hands do this. Can you see them? And that is a spasm caused by the low CO2 in your blood, carpopedal spasm. You're terrified. What's happening? I'm getting paralyzed. I'm getting palpitations. And what? You're more frightened. So you've got fear of fear. You've got fear, and you've got the fear of what's happening to your body to the point where you may actually faint and collapse, which of course means you start to breathe more slowly and you get better. This is a very common syndrome in as I said, in Afghanistan, other places I worked with. Have you seen this, any of you? Ahmed, do you have hyperventilation in Pakistan?
I don't have any experience of this. Maybe
Does
the
anybody?
participant have.
Unmute everybody, just like to hear. Has anybody seen this? All right in the chat? Have you seen it?
Uh,
Anyone? State of fear. Well, I've got, thank you about marriage stress, somebody here and there hanging. Okay, well, I'll come back to it, but have a think about it because you may see it if you start to do any clinical work. So it's good to recognize. Again, I'm sorry, guys, I pressed my pass. There we go. I've actually put this, and this may be helpful if you're doing clinical work. I've put this as a little diagram to sort of relate these things together. Remember, I asked you for thoughts, feelings, behaviors, and your body. Well, here's your trigger, the anxiety. I can't use an arrow on my slides, unfortunately, but I can on the screen. But anyway, you've got your trigger, your anxiety-provoking situation. Could be a row with your husband or wife. It could be that your child hasn't come home. It could be that your neighbor's got sick. Could be that you've just lost your job, whatever it is. And you start to worry and to think. And as you worry and think, your body is responding with the stress reaction. So you start to worry and think about your body as well as a stressful situation. There's a kind of vicious response. And that leads to you being very frightened, maybe angry and sad, and that you get this vicious circle of interacting thoughts, feelings, behaviors. They whip each other up into what we call these vicious circles of anxiety. And you're on a downward spiral because the more you worry, the more worried you become because the bigger your stress response is. I'm just going to throw COVID in here because this is actually a very classic stress producing situation in that it's not one, at least in this country, that's easy to escape. I love this slide because this is a very classic situation in this country. At the very beginning, when everybody was panicking, they behaved in a quite irrational way, buying loads of toilet paper. I do not know why. I didn't myself. Then, of course, putting yourself away with a respirator, locking yourself in your house. I think it's it's a cartoon, but it shows you. And of course, the other stress is the one, and I find it quite stressful. I don't know about you. At this country, we're all locked down and at the same time working online. So this is an old slide, but it seemed to work. So again, could you tell me now what are the stresses, the current stresses that are coming about from COVID in your country? What kind of stresses are you getting there? I would love to hear. Just write them down. Getting locked down, not being able to be, yeah. Any others? Lovely. Allows me to have a little break and drink my tea. Worrying about your career, absolutely. Now, you know, can you take your final exams? Being alone, not being able to talk to people, and worrying about your family, no treatment, allowing people to die, no proper classes in university, feeling neglected. This is brilliant. I'm going to keep this list. Self-quarantine, financial fears, fears about the spreading virus, financial stress, worrying about your dad. Thank you very much. This is a very good list. Worrying about papers, yeah. To go back or not to go back. Excellent, guys. Thank you for these responses. Okay, I'm going to put that. Haven't quite got the Zoom technique yet. Trying to move the Zoom chat. Oh. And to move the Zoom chat box and not have it take over my screen. And something related, I don't know if anybody else is a Zoom expert. When I've got the chat box open, it's hard to progress my slides. Why won't my slides progress? If anybody has, there we are. Okay. So I just made a list from a previous time I did this lecture. This was coming particularly from volunteers working in refugee camps and so on. So it's a little bit biased to their stresses, but some similar ones: fears for loved ones, fears for yourself, fears of getting sick, increased human rights abuses. And I had that slide at the beginning, doctors feeling stressed by not having the proper equipment, lack of information, misinformation, so much, an infodemic, they're calling it in this country. Not enough space, low access to soap and water, many people not being able to find the soap and water they need, lacking food, stigma if you do get sick. So those are the things. They've made this division as the people they wanted to help, but obviously all affecting you, because when you look at the list affecting us, it's not so difficult. Fear of illness, fear for loved ones, fear of violence, not being able to get at the people you want to help, powerlessness, lack of information, too much information, feeling bored, feeling isolated. And you've identified, which is very useful to me, and I'm going to keep it, the lists that are really affecting people in study, people in university. It's a particular stress for that context, and thank you for sharing that with me. Now, how is this going to affect you? I'm not going to, because of time, I could do this as a chat as well. If I'm missing something, you put it in the chat, but I know that some or all of you are going to have some or all even of these. A lot of different symptoms: getting tired, getting angry, getting sad, not having any feelings at all, forgetting things, being irritable, being tearful, not sleeping well, concentrating, not being able to concentrate. The phobic responses I talked about, the obsessional responses. I find myself really washing my hands a lot, you know, to the point which is ridiculous. Physical aches and pains, we've talked about these: losing your appetite, shutting yourself away, feeling completely overwhelmed, getting cynical, it doesn't matter, feeling hopeless, not actually knowing, not really taking care of yourself. And of course, the responses we'd like not to see but are very common: drinking more, smoking more, maybe taking drugs. Now, if you're having those responses, does that mean you're mentally ill? And this is a very important question, because you'll be asked this by your patients, you may be thinking about your family, and the answer is no. That's the first answer, okay? I'm coming on to when it might be. But the first answer is, we are in an abnormal situation. Many of us live in abnormal situations. Acute stress, as I've tried to show you, is the normal response. I am more worried about people who don't have any stress responses in these situations than I am about people who do have stress responses, because that is the normal way to react to an abnormal situation. We are programmed for millennia to have a stress response. Having no stress response, like those grey squirrels, would mean that we would die. So having a stress response is normal. It's not comfortable, and it can, if it's prolonged, make us feel extremely uncomfortable, but it doesn't mean you're mentally sick. And what your reactions are going to be is really going to vary according to the time period, according to culture, according to context, what's expected. I give you this picture because in Victorian times, and I'm going to bring this forward, was very common for almost women carried the stress. They were expected to be weak and to collapse in very stressful situations. And you have this classic Victorian lady fainting, but the man is standing up bravely and aggressively, ready to confront. And the boy is kind of between the two, both hiding but not fainting. So you have that age and gendered response in this little Victorian cartoon. I worked in Kosovo on the border of Macedonia in 1999 when 2 million people were driven by ethnic cleansing and bombing out of the country in the space of 3 or 4 days. The surrounding countries were not prepared to take them, and so at one point 30,000 people were basically penned together, standing room only, in a field next to a railway line in the rain and mud, with no tents, no foods, no water, no medical assistance. I stood outside those fences because initially the police wouldn't let us in. It was, I bring it up even now, so late, so long after, 20 years later, because it was one of the most high stress situations in which I'd been, and people were reacting classically. It was very common in Kosovo anyway, which is a very patriarchal society where women behave one way, men another, for women to faint in stressful situations. So common that I call them Kosovo fainting girls. And as you see from the press, they caught it too. You have a classic hyperventilation fainting reaction. And we had so many, and eventually the police would let me in, that we would sort of run them out of the camp to the medical tent and we would let them lie down. I stopped even trying to deal with them. I just let them lie quietly in the tent until they just pulled themselves together. Very interesting. When I worked in Afghanistan just after the 9/11 attacks, as you remember, President Bush was there, I got to know women very well, and they told me about a syndrome, which I can't remember, this was in Herat, so you would know what language that was, but it translated into escape and running away. And it only occurred, they told me, when doing domestic work, when they couldn't leave the house, when they got a sensation of choking, they couldn't breathe, they got palpitations in their heart, they got muscle aches, cramps, and pains, and even to the point, they even showed me of this, can you see my hands, this carpopedal spasm, and they had a solution. This tended to happen to women who were confined in the house, and the solution was, guess what? To run out of the house and breathe and relax, and they would feel better. And what was clear to me, listening to them describe it, was they were having mild hyperventilation, brought on maybe by the stresses of being confined alone in the house with the housework, and the release was just run out of the house and breathe, and then you pull yourself together. Extraordinary. I found it really interesting. But the husbands would come to me and say, my wife is mentally ill and needs treatment, meaning diazepam. We'll come to treatments and solutions later, and we'll talk about cultural context. But it was very interesting, the different gender perceptions of what the problem was. And then when you fit that with a Physicians for Human Rights study, that 97% of women in a sample in Afghanistan suffered from symptoms that were like major depression, but as they said in the study, were not, and seemed to be related to the conditions in which they lived. We can discuss that later, but it was an interesting study. So, do you say the woman is mentally ill, as her husband did, and treat with medication or CBT, or do you say it's a social and communal problem and address the issues of disempowerment and confinement of women, which is what the program I was working with wanted to do. Haitian Tsunami, another culture, another world, completely different symptoms after, perhaps not surprisingly, the people that came to my clinic said, we can't sleep, we cry all the time, we have aches and pains, we feel like we're choking, we have those visual memories. If we go near the sea, we feel really frightened. Don't go near the sea, especially if we see big waves. What a surprise. We remember all the time. I told you last week that they weren't avoidant, even in spite of this. And these were, to my mind, the stress symptoms that were brought about by the very peculiar event, the tsunami, which was, like the COVID epidemic today, unprecedented and producing its own symptoms. When I went to Haiti after the earthquake, and I noted all these, again, the stress symptoms were very different. I never got choking, I didn't get sleeplessness, but people would come in and say, I feel like the ground's moving. What a surprise. You can't see me. They do this. And my heart's beating, doctor. It's beating. I'm afraid I'm going to have a heart attack, and lots of headaches, lots of gut disturbance. So different culture, different event, different context, different stress symptoms. I've been in those, I give those three just as an example, but I'm very careful whenever I work in a situation to try and find out the context and the expectations of how people would behave in that culture. Now, we have ICD-11. I told you a bit about that last week. That is the diagnostic classification system, and the newest version is number 11. And they've done something which I think is very useful, and I was part of the working group that contributed to this. They have said, yes, people can have acute stress symptoms, and they vary. They can be any of these symptoms: daze, confused, sadness, anxiety, anger, despair. They can be any behaviors. You said yourself, running away or being overactive, not acting or withdrawing. You can be anxious. You can have the autonomic, you're not doctors, don't worry about that word, but the physical symptoms you've identified. Tachycardia means heart beating fast, sweating, flushing, common. I've given you, for those of you who are interested, more detail here, but the only really important bit of this slide is the word Z code, because in medical language, when we say Z code, we mean it's not an illness. The F codes are the illnesses, the Z codes are for doctors to recognize. This person may turn up in the clinic. They say they've got problems, they've got these symptoms, they've got these difficulties, but they haven't got a mental illness, which is why the title is Acute Stress Reaction. This is a big shift, because 10 years ago this was acute stress disorder. It still is in America because of insurance policies. It's not an illness. And one of the most useful things I do, and one of the most useful things you can do as psychologists, is say to people, you are having a normal reaction to a very abnormal situation. We're all feeling some version of this. I can help you. You're not mentally ill. Because imagine if you also think, I've got a mental illness, oh dear, I'm breaking down, then you're adding to the stress. This is why I'm putting such emphasis on this. I'm moving on. We can discuss it. That's all right. I'm halfway through. I'm at perfect place. That's great. I'm really sorry with this Zoom form. It's not so easy to say, do you have any urgent questions? But I'm going to break in a moment. Just be thinking, before I go to PTSD at the end of this section, I'm going to just think if they've got any questions of what I said so far before I move on to PTSD. As I said, I cannot do my whole lecture on acute stress in children. But basically, normal acute stress reactions in children are as variable as in adults. But there are some things that are special and more common. One is they tend to have more somatic symptoms and less psychological ones. Two, their behavior changes. Any of you who've got SIBS or are mums or dads yourselves or have seen children, they behave differently. One of the most common things is that they behave like a younger child. Now, if you think in psychological terms, that makes perfect sense. If you're scared and you want to be protected, the best thing is to be a little bit babyish, because then your mum will treat you like a baby. Now, unfortunately, not all mums understand that. They think, oh my goodness, why is my child starting to wet the bed when they didn't used to? Why are they screaming and crying like a baby when they've grown up now? They're a 6-year-old, not a 3-year-old. And the mums get stressed and angry instead of understanding that it's actually the babyish behavior is saying, Mum, I'm scared, I'm a baby, treat me like a baby and I'll feel better. And I spend a lot of time explaining what aggressive behavior is to mums, so that they do give the 6-year-old who's behaving like a 3-year-old, lots more cuddles and care, so they feel less stressed. That's the response. And when I talk about the babyish behavior, yes, more bedwetting. Yes, waking at night and coming to mum's bed and saying, Mum, I'm scared. Nightmares and night terrors, more phobic behavior. I'm so sorry I don't have time to do a whole lecture on this, but it is important to understand it. We do, in all of these situations, see other stress-related disorders. I'm not going to go into them in detail, but yes, you will certainly see more phobic behavior. You'll see more conversion disorder. This is a kind of hysterical conversion reaction, such as seizures that are not epilepsy is a very common one in some African cultures. People stop speaking, very common in children, just mute. Changes in behavior I've discussed. Again, each of these could have a lecture in itself, but just understand that they may occur. And there is a differential diagnosis. I dealt with prolonged grief disorder last week. I'm going to talk about PTSD. In the diagnostic system, we have something called adjustment disorders. What it actually means is if that acute stress reaction goes on too long and it's interfering with social function, you're beginning to think that this is a disorder, okay? Continuing preoccupation with the stressor, failure to adapt, and persisting, and I've put it in red, persisting beyond several weeks. That's the main thing. It's acute stress reaction that's gone on too long and is interfering with function, as long as it's not PTSD, and I'm coming to that. Now, before I come to PTSD, oh right, yes, sorry, a couple of slides here. If you're stressed, yes, you have somatic symptoms, but it is important to understand that stress, especially with singular, big, overwhelming events, can make your normal physical, your vulnerability to things like, we know this because we've seen it in the movies, but it is true. If you're vulnerable to heart attacks, yes, pushing up your adrenaline and being extremely stressed, having your blood pressure elevated, is going to increase your vulnerability to heart attacks and strokes. That is true, unfortunately. Okay, so there's an elevated risk of your physical health, especially if you're vulnerable, being affected by stress. But I already mentioned this. The funny thing is with this particular stressor is we may, in the research, this is all early days, the research is yet to be done. This is simply a clinical impression I'm sharing with you, and I may be completely wrong. Some of my clinical colleagues have said, very interesting, maybe our phobic and our OCD patients are going to do better because their particular so-called disorders are actually useful in this situation. And I've listed the ones that have obvious use: the socially anxious, the agoraphobic who have no problem with lockdown, the people who are germ-phobic, who wash their hands all the time, the ones with OCD who clean the house 5 times a day, who check, who avoid. These could be useful behaviors in a global pandemic. The research is yet to be done, guys. Maybe some of you want to do it. Okay, PTSD. Before I do that, let me go to the chat and ask you any, not comments at this point, please, but questions specifically about acute stress and what I've discussed so far. If your questions about PTSD, I'm going to be discussing that for the next 40 minutes, so don't ask about that. Anything? No, no one's typing anything. I know there's a time lag, so. Or if you've enjoyed it and understood and you just say, fine, great, carry on, that's also reassuring for me. Oh, right, yes, and that's an important question. I'm sorry if that wasn't clear. So hyperventilation is a syndrome. If you have it frequently and often, that in a sense is a disorder. And that's why I gave you a slide and you can review it. I gave you a slide on hyperventilation because if you have frequent panic attacks, that is a disorder in itself. But a one-off panic attack, I would say was part of the stress reaction, okay? It's certainly an acute stress reaction, but if somebody has them repeatedly, then you're thinking in terms of it's a disorder. The response, when I come next week, I'm going to teach you easy treatment for panic attacks. It's really easy to treat. And one of the first steps in it is understanding it. Because if you understand what's happened, you lessen that fear of fear and you don't get that vicious cycle and escalation. A pseudo seizure is when somebody lies on the floor and is shaking, but they don't actually have epilepsy. They don't have any physical disorder causing the seizure, but they're behaving as if they have a seizure, and it's a hysterical disorder. Again, these are things that lectures in themselves, I'm afraid. Okay. Any other questions? Well, we'll have time at the end. Why is violence increasing during lockdown situations? Very important question. So my off the top of my head response is that it's a high stress situation for some people, and there aren't the usual escape mechanisms. Let's take children who become more aggressive. If they're a slightly hyperactive child or a child who really gets rid of their aggression through lots of football and the same for young adults as well, and they don't have that, they're physically confined, they can't do the things that reduce stress, their stress increases, and for that person or that child, their way of expressing stress is physical, so that gets turned very easily into violence. So it could also be social in the sense that if you're in a tense situation with your partner and there's no walk, how often we teach walk away as a reduced stress strategy. Walk away is not available as a strategy if you live in a small confined place. If your whole family's there, the stresses are increased and you can't escape, so you react physically because that's the only thing you're going to do. Fainting is actually a useful thing to do. We faint because our physiology has changed, and when we faint, it actually helps us recover. That's why we do faint. So I don't have a problem with people fainting, but it's a good idea to check their pulse, their blood pressure, and so on, to make sure that it is a faint, not a heart attack. Okay? I'll come back to treatment in a bit. So we're now going on more. You're now asking your questions and more about what to do, and I will deal with those at the end of the week. Okay. So PTSD. Okay, I have the cartoon because PTSD, especially in the last 20 years, has become a kind of obsession, trauma psychology. It dominates a lot, and everybody wants to talk about trauma, the word I avoid, and other disorders have kind of got pushed out. So it is important to talk about it, but it was a controversial disorder. It didn't exist before 1980, and I will come back to the controversy, but let's talk about what it is. Why are my slides not moving on? That's it. Okay. For example, especially if you live in the humanitarian world, in which I do, this NGO is going out to help Africans because they've had a lot of problems. Well, arguably, and I know, and my husband's African, that not all their problems are PTSD. But this NGO, all they want to do is treat PTSD. And my question is, why? There are so many problems in Africa, mental health problems, including psychosis, including acute stress. Why this obsession with PTSD? And that's a very interesting question. I don't know if it's the same with Pakistan, but certainly after the earthquake, when I was working in Balakot, everyone was talking about PTSD, and I was saying, well, this isn't the only problem. So I'm talking about PTSD. It is important, but it is not the only mental health problem. Okay, but let's talk about what it is. And I'm very glad to say that, again, with ICD-11, this new diagnostic system, I've put it here for you. I'm not going to read these slides. But I think the diagnostic category that exists in ICD-11 is good because it's tightly defined. First of all, to have it, you must have been exposed to an event that is long-lasting or short-lasting, extremely threatening or horrific. Now, I think COVID-19 is extremely threatening, and also when your relatives are on a ventilator in a hospital, that's horrific. So it's no question in my mind that COVID-19 might qualify as such an event. Earthquakes certainly do. as you've experienced. So do floods, which you have to a terrible degree in Pakistan, okay? Not limited to natural human-made disasters, well, there you are, COVID and floods, combat, serious accidents, sexual violence. I will come back to that. It is one of the biggest predictors with the most severe effects. Very interesting. We can talk about why. Sudden death, unexpected, violent, especially if it's a loved one. Then, following this traumatic event, the development of a characteristic syndrome, and note this, for at least several weeks, because all the symptoms I'm going to describe, as I already said, can occur immediately after the event, but if they disappear, they're not PTSD, nor are they predictive of PTSD. But if these symptoms, these 3 symptoms, go on for several weeks, then you have PTSD. You must have all 3. Re-experiencing. That means you see or hear or relive the event in one way or another. Now, it may be the same nightmare every night. It may be flashbacks. It may be hearing the plane coming over your head and knowing it's in the sky. But this is not, oh, I thought about the bombing. It's without your choice, that plane buzzes over your head and you hear the bomb beginning to fall, or you see the wave coming up the beach, or you feel the ground is shaking and you see the house falling around you. These are re-experiencing events, and believe you me, when your patients describe them to you, it's easy to say this person is re-experiencing. It is not the same as, I find it hard not to think about what happened. That is not intrusive. It's when the thought is pushed into your mind or the experience is pushed in. And what happens? This tends to happen when you go down that road or go back to your village or go on the beach or go near the hospital or stand in that situation that reminds you. So guess what? You tend to avoid the places that trigger the re-experienced situations. So you get this combination of flashbacks, re-experiencing, and avoidance. You avoid going to the pub because that guy always starts talking about the war, and then you're back there in the trench. That used to be a common thing with, war survivors. And obviously, if you're re-experiencing and you're avoiding, you're also, in a sense, on the alert, ready for that bad situation to happen. That heightened sense of threat, sometimes called hypervigilance, is the third important symptom. So you have all those 3. I hope you've understood those. As a result of all those 3 going on for a number of weeks, you can't actually function normally. If you're a fisherman that used to fish off the coast of Sri Lanka in a fishing boat, and you no longer go out in the fishing boat because you're terrified of another tsunami, your social function's annoyed. You aren't earning money, the family are angry with you, you're not coping. You're a young man who had a serious car accident, you're a driver of a delivery van, the van crashed. Every time you get in the van, you see that other car coming towards you, you can't get in the van, and you feel tense and ready for that crash to happen all the time, you stop driving your van. You understand how I mean? It affects your social function. You don't go back to those situations where you think about your dad or your mum, because it reminds you that when you were with them, then there was a kidnapping or whatever it was, you survived, they didn't, you avoid the situation. Occupational, or maybe you don't want to go to school because there was an earthquake or there was a bombing, and that's where you think about it happening, you re-experiencing it. It stops you functioning in a normal way. Okay, I've gone into those in more detail on the slide. You don't have to take notes. I hope I've written everything that you need. Now, that's very important. You've got to have those 3 symptoms. Now, in the old days, and especially in DSM, they didn't say you had to have those 3 symptoms. They had a whole list of symptoms that you might get after a traumatic event, many of the acute stress symptoms that we've discussed before. And if you had them and you'd had a traumatic event, you had PTSD. Now, actually, this is very worrying, especially when we come to the research, because when you look at the research, it's all done over the last 20, 30 years. 1980 was when the diagnosis was first made, and it was made on clusters of symptoms that today we would not diagnose as PTSD. So I don't know if any of the old research on how common is PTSD is really valid, because all of these symptoms used to be listed as, oh, you've had a traumatic event, you're a little bit anxious and worried, you're a little bit obsessional, you've got some physical complaints, you've got PTSD. I would work in countries where basically, and this was particularly common in the Balkans, if someone came in and said, you know, my son has seen the soldiers come to the village, his mother's died, he's not sleeping very well, the doctor would go, like, PTSD. It's not. You need those three symptoms. And that's why I've spent so much time on acute stress reactions, so that in the first few weeks, that's the diagnosis you may be making, not, oh, he's got PTSD. It's not helpful to label someone with a serious mental disorder, and PTSD is a serious mental disorder, when they haven't got one. It is important to recognize it when they have one. I hope you understand the distinction. So I'm not going to go through this long list of symptoms, but you need to be aware that in PTSD, as well as the three core symptoms, you may have any of these. You may also be depressed. It is very common to have PTSD, depression together. You may be also drinking a lot, very common. Vietnam veterans, it was a sort of classic story. You have the PTSD symptoms, they're not recognized, and you treat them yourself. And how do you treat them? Guess what? With the easily available drugs, alcohol or drugs. In young people, and now we're understanding this is more complex, but in young people, and I see this in this country in my own clinic, who've suffered severe physical or sexual abuse, it may later, unfortunately, compound itself as personality disorder. That is a whole lecture in itself. I'm not getting onto complex PTSD and borderline personality disorder, but yes, they go together. As not a surprise, somatic complaints commonly accompany PTSD. The more the person has a complex mix of disorders, the higher the suicide risk. That isn't surprising either. How common is it? Right, well, I've told you, be very wary of all research, because I think prior to ICD-11, the diagnosis of PTSD was so globally variable that I really don't know how to make sense of it. But anyway, I've given you the research and I've given you the references, because the interesting thing is, and now look at the one I've put in red, there have been these big countrywide lifetime studies of how common is PTSD. And in the US and Canada, where more than 80% of the population have been exposed to severe and potentially traumatic events, not surprising when you hear how much gun violence there is, but anyway, 80% have been exposed, only 8.3% have a diagnosis of lifetime PTSD. That's very interesting to me, because it's such a popular disorder, you might expect it to be more common. WHO lifetime prevalence in upper middle income and lower middle income countries, 2.3 and 2.1% respectively. Basically, the message is, it's not as common as you might think, given how common traumatic events are. But then you turn that around and you think, well, actually, that makes sense, because human life is not easy, especially not easy in Pakistan. I know you have, as last week I said to Ahmed, you told me I really stuck in my mind. You said, yes, COVID's a concern, but we have so many other concerns, typhoid fever, flooding, natural disasters, poverty, violence. And so, life is tough. It's not a joke. And if it knocked us out and made us all seriously mentally ill, we wouldn't be here. The message I'm trying to get across is we're pretty resilient. So who's most vulnerable is the important question. And when you start to look at what kind of traumatic events really are likely to give you PTSD, it's not your floods, disasters, and your wars. If you're a civilian, I'm coming to soldiers, but if you're a civilian and exposed to organized violence, 3%. if you're in a sexual relationship where your partner treats you violently, or if you have a child exposed to sexual violence, 33%. Please note the difference. Intimate violence, and I've seen this again and again, can cause much more PTSD than being bombed. A colleague of mine, very famous, did a study in Afghanistan where children had obviously been exposed to long-term war, and she found that children saw family violence, physical and sexual abuse, as more worrying than being bombed. And I found the same in qualitative research in the Balkans, that the child who had witnessed domestic violence between her parents all of her life, even though she was exposed to 4 years of siege and bombing, found the sexual and physical violence more disturbing. And in a way, if you think about that as psychologists, that isn't surprising, because the threat that's inside your house, the parent who beats you or who beat each other, or the parent who sexually abuses you, is much more terrifying and more difficult to escape than the bomb outside the window. Very interesting research. Okay, but let's look at war-exposed populations. It is a variable on self-report measures where they're saying to themselves 70%, interviews 10 to 30%. In conflict-affected populations, you have these other rates. So very variable. And look, 10%, 15% is 10 or 15 in every 100 people. So that's not a small number. I've given you some other research in more detail for those of you who are research-minded, again showing you rates of PTSD were not as high as expected. I've given you some children's research. I'm not going through these slides in detail. The biggest thing to note is the diversity. Why? If those of you who are researchers, different measures used, interviews, self-report, different symptom checklists, different events, different samples, and then there's the cultural validity of the instrument. And this is a big issue, because what happened in the West, in a sense, you could say we invented PTSD in the 1980s. We suddenly put it in the diagnostic system. And then Western researchers, and I saw them because this was my generation in the 80s and 90s, we went all over the world with our Western checklists, and we asked in a Western language whether you had this disorder. And really it's a question as to whether we were actually labeling symptoms that were culturally normal behavior as PTSD. Secondly, and this wouldn't be an issue maybe in your country, but it certainly is in mine, people have learned if they say, I have these symptoms, that may actually allow them to get compensation or asylum. That's very important. And I understand, but it makes it very hard to know whether somebody genuinely has the experiences they're saying, or is saying because they know that when you write the medical report for the asylum application, they're more likely to get asylum. That is a problem today. Another interesting study, and it's an old study, but it's very important. There was 2 villages in China, and they did a very interesting study where they found that the 2 villages, the one that had the most exposure to the earthquake, in the 1990 earthquake, those old enough to remember, was a big earthquake, had less PTSD than the village that did get more. So what happened is, if you got more relief, you had less PTSD. Okay? The village that didn't get so much help because it wasn't so exposed to the earthquake had more PTSD. Why would that be? Perhaps because they realized, or not they realized, it was subconscious. They were more stressed and more distressed for a longer period because they weren't getting the help that the village who got more problems got. Very complicated, especially if you're a relief worker. Now here's the good news. If you have PTSD and you don't get treated, a lot of people still get better. You look at this first study, 70% of the women, 50% of the men diagnosed with PTSD. Now their diagnosis was made quicker than we would make it today, 19 days after an assault. 4 months later, 0 for men, 21% for women. This also confirms for me what I said earlier. You need to have a longer, more persistent problem. I think a lot of these people probably didn't have PTSD, but even those who did, rates of self-recovery are high. Okay? Same with the next study of rape victims. 2 weeks post-trauma, the diagnosis was made, it had fallen off. Same with people, MVA, okay, that is Medical Veterans Association. They had remitted a year post-trauma. Now, this is perhaps as psychologists one of the most important slides. And I'm sorry, there are a lot of words on it. But when you come back to review the slides, take a look at this. Because this is what matters to us is how do we prevent it? How do we help people get better? What makes it get worse? Now, it's very interesting that it would look like you're more likely to get PTSD if you're female, but that may be something to do with the high rates with sexual violence, because unfortunately it is true that women are more exposed to sexual violence than men. I know that men and boys suffer from sexual violence, but women tend to suffer it more. If you're older, you may have more. Previous psychiatric problems definitely predisposes you. We think there may be some genetic vulnerability. If you're living in a stressful situation, and unfortunately many people in Pakistan are, this can increase your likelihood. There are also, some people love this kind of research, if you have certain experiences when you're having the PTSD, if you're highly aroused, you're more likely to get this. Let me give you an example, and I saw this, I've written a book about Bosnian children. If you're interested, I can give you the reference, but it's not a clinical book, but I did lifetime interviews with war-exposed Bosnian children. And the children who had classic PTSD were the ones who had, for example, stepped in dead body parts. So sight, smell, taste were all affected, or had an explosion. One child had a friend blow up in front of them. That's a horrible experience, but you're completely aroused by it. All your senses are involved. This seems to lead to more PTSD. First World War soldiers who had the same experience report the same kind of thing. Your cognitive style, the psychologist, that will affect you. If you're naturally a catastrophizer, someone who always sees the worst possible aspects of every event, you're more likely to get PTSD. Certainly, more exposure, more PTSD. And I think that helps you understand sexual and physical violence. The children I see in the clinics in Britain, the children who come to me as patients, they're ones who've sometimes been exposed for 3, 4, 5 years. It's not a one-off event like a war or a flood or a tsunami or a bombing. It's every day, every night. Is my dad coming in the bedroom? Dose response, very high. Unpredictability and lack of control. I can't control these events. Disasters are very uncontrollable. Maybe COVID, because we can do more, will not lead to such high rates. The research has got to be done. Greater sense of responsibility, certainly if you're a fire officer, an ambulance man, any of these people who are frontline responders, and this may be very important for COVID. If you feel responsible, you feel you're letting your people down, this appears to contribute to it. So we need to be looking out for those people. And then what can help the disorder continue? Social isolation. I put that up the top because what are we doing today to protect ourselves? We're asking people to isolate themselves. So on the one hand, they're exposed to this stressor, and on the other, one of the things that we know is a major protective factor, being socially connected, is actually not available to us. I don't think the internet counts. Loss of culture is very important for migration and refugees. Shame-inducing, of course, if women are raped, and I saw this working in refugee camps where women who'd been raped, instead of getting help, were isolated and stigmatized. Continuing legal problems, unemployment, as is happening massively with corona, work pressures, again, both unemployment and work pressure. Certainly the epidemic is producing both of those. People knowing that they may get compensated can actually, in a subconscious way, to lead to their symptoms lasting longer. I've already told you about these protective factors. Social isolation, so having support from your family and friends really helps you. Having meaning systems that helps you make sense of the events. And someone, again, a very nice study after the tsunami, because it was such a cross-cultural event, and now you can do the same research today. They found that people didn't matter if it was Buddhism or Islam. The people who had a religious meaning system were protected. Cultural continuity, not leaving your home, staying within the culture that you know, is certainly protected. And there's something called stress inoculation. You know, if you're prepared for something, if you know it's going to be bad, and again, firemen, ambulance men, doctors, they may have an advantage here because you train for emergencies, you prepare for them, and that's supposed to help. I know what to do here. Okay, I've got 15 minutes. I'm going to just spend, I'd like to give enough time for questions. I'm just going to spend a little time on this because there is a debate. If you're interested in this disorder and you go into the literature, you will come across literature that says it doesn't exist. This is a made-up disorder in the 80s. It's to do with our preoccupation with victimhood rather than resilience. It's a Western disorder that we've imported to other cultures. And the most important point here, we ignore social, political, and communal concerns. The people are not actually sick. They actually are suffering because of political and social situation, and then we label it as a disorder, and we don't have to deal with the political problems that cause it in the first place. This is just to show you there was no literature in 1980 on PTSD. Nobody's repeated this study since 2005, so I can't tell you now, but in this study, and I've given you the reference for this, in this study they looked at the escalation of literature on PTSD in those 20 years. It was just extraordinary. And they argued, it's a very interesting discussion, that we had much lower rates of mental disorder in World War II because we understood, we moved our understanding from people being resilient to an understanding of victimhood and weakness. And we began to look not at, oh, this person is biologically vulnerable to mental disorder, to external stressors, especially with soldier populations. The big population that led to the invention of PTSD was Vietnam. The soldiers came home, and instead of saying, you're a bad person, you're mentally ill, there was an argument that actually it was the external stressor, it was the war, it was the political situation that was causing their illness. So instead of the soldier feeling bad about himself, he could say, I've got PTSD. Don't tell me that I'm a drunken, substance abusing soldier who's causing a problem. Recognize that you put me in a bad situation, and that bad situation made me mentally ill. So it allowed the person to shift from having something wrong with them to a disorder caused by an outside event. And PTSD is clearly a disorder caused by an outside event. It is one of the few psychiatric disorders where no one ever says, oh, you're kind of morally culpable. Even with depression, people say, oh, come on, pull yourself together. If you just did this or you just did that, you wouldn't be depressed. But with PTSD, they cannot deny that you have suffered an external event. It is the only event in my country, it's the only disorder in my country that is almost a badge of suffering. Look, I've got PTSD, I must have suffered some bad event. Nobody ever wants to acknowledge that they've got psychosis or depression or anxiety, but nobody is shy of saying they have PTSD. That is in Britain. I don't know in Pakistan, it would be very interesting. But some people are complaining that there's too much PTSD because PTSD is a label of suffering, that you've done something, something's happened to you, that you're a victim, you can't be blamed. I hope you're following what I'm saying there because it's a little bit complex. You're nodding, Ahmed, right. And then there's another wonderful man, I'm just throwing him in. If you ever read anything by him, it's really worth it. Kleinman, Arthur Kleinman, still alive, teaches at Harvard, and he makes this very important point. He's a medical anthropologist. Symptoms have different meanings for different cultural groups. I already told you last week about my Filipino housekeeper's friend looking after my grandmother. She loved her dreams about my grandmother. She did not see them as nightmares. She saw them as messages from the dead. Having bad dreams is not always bad, okay? If you're a child, I've mentioned hypervigilance in wartime. All the children I work with in Bosnia were hyper alert all the time. Very good thing, because they were listening. Is a bomb going to fall? You need symptoms in different situations. After I had a child die in front of me, one of my first experiences of a child dying, I don't remember if I told you about this in the last lecture, but I'll tell you again. I tried to resuscitate the child, and the child bled. It was very physical, the blood came in my mouth, the crash team came, they pushed me out the way, the child died. I relived that experience. It was a classic flashback for the next 10 days. And I couldn't stop crying, thinking about her, and I didn't really like going on the children's ward, avoidance. I didn't have any hypervigilance, but I had 2 symptoms of PTSD. And if I'd probably gone to a doctor, well, they wouldn't have diagnosed it because it was 1978. The diagnosis didn't exist. But I just played this movie of this child dying and failing to resuscitate again and again. I couldn't stop it. It was in my head for about 11 days. And then just faded away. I'm glad no one diagnosed PTSD. I didn't see myself as mentally ill. And what I realized afterwards, and I realize now, that was an acute stress reaction. That was an acute stress symptom. And I was digesting the experience. It needed to replay so that I could make sense of it. And then it disappeared. I didn't need it anymore. Completely different way of looking at that symptom. I give you this last slide. Take the time to read it because it is important. A phenomenon, the expansion of the PTSD model, referred to as criterion creep, highlights a critical shortcoming of traumatology, the cross-cultural medicalization of normal human emotions. Labeling situation-based emotions and upsetting thoughts as symptoms is like saying that someone's cough in a smoky tavern is a symptom of respiratory disease. Illogical leaps increasingly inform our cultural narratives when we discuss human reactions to stressful events, giving rise to iatrogenic, that means medically caused, misapprehensions and contributing to chronicity. I'm very glad I wasn't diagnosed as having PTSD. That would have made me feel worse and maybe prolong those symptoms. Now, if my symptoms had gone on for a month and I found I wasn't functioning well and avoiding the children's ward and feeling anxious all the time, I would have wanted medical help. I hope you understand that important distinction and the value of having tight diagnostic criteria, which I have given you. I hope you'll take the trouble to read through these slides and take in a lot of information that I've given you quickly. Why? Because look, the media are on it already, just like after every traumatic event. We're all at risk of developing PTSD from the COVID-19 pandemic. This is a popular magazine called In Style, already predicting that we're all going to get PTSD. Give me a break. Now, it's a sensible article because it points out that the vulnerable person is actually a young woman who's had previous psychiatric disorders, previous trauma, and they're right. She is more vulnerable. But they're also saying that all of us can get it. That's not a helpful headline. So it's very interesting that we're seeing the same thing that I've seen with previous disasters and wars. Everyone's going to get PTSD. Not necessarily so, but you need to understand the disorder. You need to be able to distinguish it from acute stress reaction. If you're concerned, you need to be able to refer on. And I'm going to talk about treatment in the next lecture, and we've got 5 minutes left for discussion. Any questions, guys? I can stay 10 minutes if it goes on.
Now you have to access to unmute yourself. So if you have any question, just unmute.
Questions out loud would be lovely. I love to hear voices. Yes. Ahmed, I'll give you the slides in the Dropbox anyway. And what I'd ask you guys with the slides, I'm giving them to you as slides. That's very nice of me. Please do not publish them. There's photographs that I haven't got copyright permission and so on. I've just used because I'm teaching. Please just keep the slides to yourselves. Yeah.
Sure.
Trust you on that.
So, my question is that the most PTSD is developed in the rape victims. So, is there any legislation in the law to stop this thing for the rape, for maybe the death sentence for the rapist, or the West support this?
You tell me. I mean, you're in Pakistan. How is rape treated there? I mean, we don't
In
have the death
Pakistan,
abolished.
in Pakistan recently, the parliament passed the law that the rapists get the death sentence, but the NGOs, mostly the NGOs, get from the funds from the Western. They are oppose this law. I don't know why.
Okay, there are two things here. One, is rape a serious crime? Yes. And it is very disappointing that a woman in India can be raped on a bus. And as I understand, it took a very long time to bring even some of the perpetrators to justice. I don't know the situation in Pakistan. So is rape a serious crime that should be treated to the full extent of the law? And that includes in my country, in my lifetime, when I was born, there was no such thing as rape in marriage. If you were married to someone, they could rape you, i.e., they could sexually assault you. You didn't want to have a sexual relationship with him that night or whoever. It can work the other way around, but it's more commonly a man or woman, a man raping a woman, and that was not a crime. In my lifetime, that's changed. It is now recognized that a married woman can be raped by her husband. Thank goodness. In many countries, that is still not the case. So, one, I believe that rape is a serious crime that must be punished by the full extent of the law. Now, I, like many of my contemporaries, and I think many of the NGOs, do not think that capital punishment is right in any situation. That is largely because we can get things wrong, okay? We don't, I'm not a religious person, but I actually think our human right to take away another person's life under law is a bad call because, as you see, some people are wrongly accused and then there's no going back. But secondly, actually, I do think, sorry to say this, and this is, life imprisonment is a better punishment. It really is. And so, no, I'm opposed to capital punishment. That does not mean I don't take rape seriously and think it is absolutely a horrific crime that should be punished with the full extent of the law. Any other? It's a big discussion, but that's my view on it. Yes.
Mm.
Any other questions? How to overcome sleep disturbance. I'm going to be talking about this stuff next week. Thank you. It's a really important question. We'll talk about managing sleep. I'm even going to give you some exercises. So I won't answer that now. Anything else? Anyone? Do call out. I can't believe I've given a lecture that doesn't have any questions or other comments on it. How would you deal with nurse? Are you talking about Mr. I'm sorry, I'm going to read this question out because it's really good. How would you deal with narcissistic personality? That is a whole other lecture, narcissistic personality disorder. And unfortunately, we have a lovely example of it today in the most powerful country, or not anymore the most powerful country in the world. So I think we ought to be thinking about it, but I'm not going to talk about that here. But thank you for putting the question. For a start, I would get him out of office. He shouldn't be running the United States. Yes. I think expressing anger is obviously good for your mental health, but how you express it and where you express it is the question. So, I say to my angry children, is there another physical outlet apart from bashing up your little sister when you're feeling angry, or breaking the china, or screaming, because verbal anger is also aggression, screaming at your mother? Is there another way? Now, of course, going outside to an empty place and having a good shout, not easy in crowded and shut down places, is one way of dealing with your anger. Another is to write it down. Another is physical exercise. When I was very small, I'm a child psychiatrist, so forgive me giving more examples from children, but my mother would give me a hammer, some nails, and a piece of wood and say, darling, go in the garden and put these nails in this piece of wood. I'm not joking, worked very well. Actually, yes. I don't think breaking the TV is good at all, but you should channel the anger. So anger management is a whole, again, you're bringing up such good questions. These are whole lectures in themselves, but we need to come up with ways to manage anger, and they're very important in this situation.
I have a question.
Yes.
I don't know in your country, but in my country, if I on the TV, on the news channel, I saw that the news is that 80,000 people died in America, 30,000 people died in UK, and 25,000 people died in Italy, and or they are very advanced country. Maybe the people has died in Pakistan, and that and that and that. So, and people are in lockdown. If we are watching so much media, maybe they will develop PTSD symptoms or the passive trauma, not a direct trauma. They will see maybe watching too much news or like this.
I don't think, first of all, I think watching too much news certainly will increase your stress and your anxiety. I don't really see, I'm not a great believer in vicarious trauma from watching the news. Although, you know, people say, oh, watching 9/11, I got PTSD. I certainly think it can stress you. I think you should limit the amount, especially children are exposed to endless. First of all, there are other things happening in the world. You know, who cares about a bunch of women with babies being killed in a maternity ward? It is shocking to me that some things are not covered and some things are. I'm sorry, we've become so self-preoccupied now that global events like starvation in Yemen and massacres in Afghanistan don't get any coverage. That's shocking to me. But I don't want to, you know, that's traumatic as well. I also think we should think about what's good. We should be looking at other things in our lives and terrible events. And certainly wall-to-wall coverage of the pandemic is not good for our stress levels. Mm. Okay, we're getting on to discussing anger. Um, I'll try and think a little bit about anger management when I talk next week. The trouble is I've got a lot to cover, and that is a whole thing in itself. So I'm not sure I'm going to be able to cover that, I'm afraid. But I recommend that you look up anger management as a strategy. Self-help for PTSD. I will talk about treatment of PTSD next week. Any other quick? A lot of you are getting onto treatment now, so probably we're into not next week, Friday's lecture. So
Yes.
so somebody said, how is stress different from post-traumatic stress disorder? I don't know what to do because that was the lecture. So I suggest you read carefully through the slides, and I apologize for clearly failing in giving this lecture because that was the whole point of the lecture. Anyway, don't know what to do about that, Sarah, except suggest you read the lecture through and see if you feel I've answered your question. Interesting. Okay, any other questions? No. Okay. So, I mean, we can have a quick chat about Friday, and everybody else, I'll say thank you very much. I look forward to meeting you again at 11 o'clock on Friday.
Yes.
Yes?
Thank you so much for your time, your precious time. The lecture is fabulous. The people gave me the feedback. They are very happy, and thank you so much for your time. And
okay, that's okay. Ahmed, you're going to stay just to talk about arrangements for Friday? Yeah.
yes, sure.
Ahmed? Yeah.
Yes, sure.
Okay, so everybody else can go. Or yeah. Pleasure. Pleasure. Thank you. Just trying to disable my stop share. That's it. Good. People are taking their time to leave or turn off.
Yes, please leave.
Just close it. Just leave the lecture, guys.
Miguel. Okay, I will.
Can we close and rejoin? Can I leave and rejoin?
Yes, okay. I will email
stay.
you the link. I will email you the link. Okay.
Okay, great.
In a second. Okay. Thank you. Thank you so much. Allah Hafiz.